I'm really honored to be here again with you all. It's you who kind of keep us going and keep us driving forward for new discoveries. So when we were trying to figure out what I should talk about today, we thought about, obviously medicines, there's coag stuff we could talk about, but a lot of people now are using medicines, and some people are very close to vascular anomaly centers, and some people are not so close to vascular anomaly centers. So as we're starting these medicines, a lot of people are being treated with medicines from afar. And I think that's good and bad. So it means that you all not only have to educate your physician about your condition, but you also have to educate your physicians and work with them as a team to work with the medical therapy. And so we thought that we could just sort of go over what does it mean to be on sirolimus? What do you really need to know about certain aspects about it? And what should you and your doctor be working on together about that as well? So that's where we came up with this topic. So just for a show of hands, how many patients or family members right now are on sirolimus? Okay, so that gives me a good idea. How many people have been on sirolimus and are not on sirolimus any longer? Okay, thanks. So we'll talk a little bit about, I don't have any disclosures except that Sirolimus, or Sirolimus, whatever you want to call it, we'll talk about kind of that in a second, has not actually officially been approved for the use in vascular anomalies, and we're actually submitting an application to the FDA to have it not approved officially, but approved for orphan drug status for vascular anomalies, and we'll be doing that this fall. So basically, when we think about medical therapy, why do we consider medical therapy? And so sometimes we consider medical therapy because we want to cure a disorder. And sometimes, when we think about, I'm an oncologist by trade, a hematologist oncologist, and so when I treat cancer, I really want to get rid of the cancer, I want to cure it. And sometimes we use medicines to control disease because we know that, a disease might be congenital, like KT is and other overgrowth syndromes, and we want to control the disease so you don't have a lot of the side effects from that process, or it doesn't lead to other effects. And sometimes we use medicines because we want to control the symptoms of the disorder. Sometimes we're thinking of medical therapy because we know from experience what short-term issues are with that disorder and also long-term issues, and we want to use medication to kind of help that. And sometimes by using medication to treat a disorder, it actually might help the other treatment modalities we have, such as surgery or interventional radiology. So, for example, I think that in a lot of places we've made great strides with sirolimus, and so when we have a patient that comes in as an infant even with Klippel-Trenaunay or another type of overgrowth syndrome, sometimes if we treat them with sirolimus early, we can actually control the disease to the extent that the surgeons now tell us that their debulking procedures are easier to do. So there's more sort of to that, but I think those are things that we need to look at in the future as we're exploring what the indications are for these medical treatments. And so how do medicines work? Well, some medicines, like again a cancer, work because they destroy a specific cell. So cancer is one cell that's growing out of control, and medicines will destroy that cell. And sometimes medicines stabilize a process that's happening. So sometimes you can have a proliferative process and medicines kind of stabilize that, and in doing so that helps in general with the condition. Sometimes medicines help the surrounding environments because sometimes when you have a disorder, it can send signals and it can cause havoc to the surrounding environment. And sometimes medicine helps with that to kind of stabilize that environment around the disorder. And sometimes medicines control the effect of the disorder by interfering or helping with other physiologic means. And nowadays, there is sort of a new way that we're using medicines, and that is really personalized medicine. And has anybody read about that in like Newsweek or Time Magazine? Like Time Magazine had a big section on this. And that's really when we kind of look at the person and we look at what that person has, and we see if there are ways that we can direct our medicine to what the issues are. And a lot of this comes down to genes, and I'm going to talk about that in a little bit. So what is this medicine that we call rapamycin or rapamune or Sirolimus, or if you actually look in Wikipedia, it's phonetically spelled out as Sirolimus, though my Pfizer contacts call it Sirolimus, so I call it Sirolimus. But this was a medicine that was actually discovered in the soil of Easter Island. So when we go out there and we look for medicines for different things, sometimes we look in different areas. And so it was discovered in the soil, and it was first used as a medicine to fight against fungal infections. And then when they were treating fungal infections, there's a fungal infection called Candida albicans, which is a pretty common type of fungal infection. They found that some of the other side effects of this medicine were that it was immunosuppressive, so it suppressed someone's immune system. So in 1999, it actually got approved for use for patients who were having kidney transplants to decrease your immune system so you wouldn't reject that new kidney. And then from there, it really has expanded because they found that this medicine basically has anti-proliferative properties, and that became very, very important. And I don't know if you all, again, saw Newsweek or Time Magazine, but this medicine is in research, and it's called an mTOR inhibitor, and I'll explain why in a little bit. But this medicine is undergoing research for every different kind of cancer, so it's part of a lot of protocols with a lot of different adult and pediatric cancers. It's also used in other things, so there's something called LAM, which is a disorder of adults, where they have a lymphatic and a muscular kind of component, and they can get pulmonary disease. And Sirolimus was used with that and actually has been FDA approved for that. It's being used in pain syndromes, in lupus, in something called tuberous sclerosis, in Alzheimer's. And the big reason it got sort of on the cover of Time Magazine and Newsweek is that in some mouse studies, it seemed to prolong longevity. So there was a question as to whether it actually it would, affect aging. And so that's where this whole big kind of commotion came about. It is not really what I consider cancer treatment, though. So I know I'm an oncologist, and I know I use it to treat cancer, but when I think of it, what a chemotherapy agent is, a chemotherapy agent is something that fights fast-growing cells, something that's really used to kill fast-growing cells. And Sirolimus is really not that. Sirolimus is more of what we call in oncology sort of a modifier, a biological medicine that sort of modifies things. So I know people are scared sometimes when oncologists give them medicine because they think everything is a chemotherapy, but I don't consider it a chemotherapy. And in cancer, we're using a lot of medicines, again, for personalized care that aren't really under that killing cell kind of chemotherapy sort of category. Does everybody kind of understand that? Because I think it scares people when an oncologist is giving me this medicine. So this is basically a schema for where Sirolimus works. And I know this is a bit overwhelming, but when we think about processes, like you have different processes in your body and you have different genes and you have different proteins in your body that are responsible for things. And this particular medicine attacks a pathway called a PI3 kinase pathway. And if you see it, that's sort of up in this area. And this pathway is made up of proteins and genes that regulate growth of cells. Okay, I'm going to have to be turning this. But, and it regulates growth of blood vessels, not only lymphatic vessels, but veins and things like that. So it's really, really important to us in all of those disorders that have to do with the growth of cells and the growth of blood vessels. So when we were first trying to figure out what other medicines that we could use, this pathway became very important to us because we knew that there were some medicines that were involved in this pathway. So again, this is a pathway that starts with a protein and a gene up here, and different pathways lead into this, but the end result is that you have growth of blood vessels and growth and proliferation of cells. So if you can figure out a way to block this pathway in some way that maybe are related to blood vessels, we thought, you know what, maybe we can help patients that have these disorders. And I don't know if you remember a year ago, but I talked about that one patient that we used this medicine on, and it made this patient responded to it, and that's why we have this medicine now that's used to treat these vascular lesions. And you can see that our hypothesis, so this was before we knew what the genes that were involved were, that our hypothesis that this pathway was involved wound up being correct. Some people may think that that was just chance, and it was a good chance, but there was some brain cells that went into trying to figure that out. And so now we know that when we take tissue from a patient that has a vascular malformation, and we look at the genes that are involved in that malformation, that there are some abnormalities of the genes, and those are called somatic mutations. Those are not mutations that you have inherited from your mother or father. Those are germline mutations. These are changes in the actual tumor. I'm going to say tumor because it's a growth. Okay, I don't mean a cancerous growth, but there are changes in that tissue that are somatic mutations. And so you can see that a lot of things that we take care of have changes in this PIK3CA gene, and those are lymphatic malformations and combined lesions and cloves, which is an overgrowth syndrome as well. We knew that there were some, and again, germline, so P10 mutations can be inherited, and then they can not be inherited. So somatic and germline mutations of this gene called P10, and patients that had this also had an increased risk for vascular anomalies. We talked a little bit about tuberous sclerosis and those patients actually having some response because they can get tumors that are made up of blood vessels as well, and Sirolimus helps treat those patients. And then we also have venous malformations that have mutations in TIE2, and we have other capillary malformations that have mutations in RAS1. So all of this sort of saying that this pathway is very important. And so when we think of, okay, this pathway is very important, what medicines do we have available that might block this pathway? And that's where the Sirolimus comes into play. And so this is mTOR here. Sirolimus blocks this pathway right down here. And we sort of, again, made a hypothesis that this would work, and it does work in the majority of patients. Some patients it doesn't work so well with, but in the majority of patients it does work. But this also, and I'll talk about this later, gives us an opportunity to think about what other medicines might be available to help us. And you know, when I think about medicines, I truly think about using medicines in an interdisciplinary fashion, because it's not only the medicines that are going to help, it's the interventional radiologists, it's the surgeons, it's us working together as a team to come up with what we call multimodality treatment. So treatment that involves a medical doctor and a surgical doctor and an interventional doctor. Does everybody understand that? Because that can be a little bit complicated. So what we did from there, and you all know this because I talked about this the last time I was here, but we took that medicine and we kind of treated very complicated patients with that. And then we actually wrote a study for the use of Sirolimus to treat complicated vascular anomalies. And we looked at, number one, does it work? And number two, what are the side effects? We knew the side effects from, you know, the renal transplant patients, but this is a different, you all are a different group of patients. And you all could have different side effects to this medicine. We didn't know that, and that's why it was important for us to study that. And so you know that the overall response was very good. We treated this response like a cancer definition, and so when I present this even to hematologists, the hematologists are like, what are you talking about? There's only partial response. These people are responding. But complete response meant that your disease was completely gone. And we really didn't think that that would happen because it was a congenital problem. But we still needed to use those very tight definitions for what response was. And so we truly felt that if it was going to respond, we would get a partial response and no one would really have their disease completely gone. Okay? These are pictures that you saw the last time we were here, that most definitely for lymphatic malformations that are microcystic, this medicine works. Remember, it doesn't completely make this lesion go away, but you can understand that surgery is going to be a lot easier here than it was up here. We know that it can help, Mega talked about those lymphatic blebs. So these are lymphatic blebs on the tongue. It also can help with the lymphatic blebs that you have on your extremities. We've used topical sirolimus as well. There are some issues with topical sirolimus because it has to be compounded and we need to work a little bit further on doing that. But certainly oral medicine definitely affects the vesicles in a very positive way. We know that it does affect bone lesions as well, so you can have improvement in those lesions. We know that there's some people can have fluid in their lung or pleural effusions, and it does help that. For the patients so remember, this was 60 patients, but they were very complicated patients because we felt if we were going to use a new medicine, we really needed to treat the complicated patients. And they were all different kinds of vascular anomalies. So I know you all are aware that the International Society for the Study of Vascular Anomalies redid the classification system. So in this study, there were many different diagnoses that were included. So it was really hard to say, okay, this diagnosis had 60 patients. That wasn't possible. And so it was hard to take out each of those diagnoses and really see, did it have a great effect or did it not? Does everybody understand that as well? So if you looked at the patients that had capillary lymphatic venous malformations or capillary lymphaticovenous malformations, the biggest advantages that this medicine had is that it didn't really help your imaging, so your radiologic studies. Those really stayed stable. Some people who had more of an overgrowth syndrome with a capillary lymphatic venous malformation, sometimes it did actually affect those radiologic imaging, but most of the time the imaging was stable. But it improved the patient's quality of life, because remember, when we were looking at response, we were looking at what did it look like radiologically, it's sort of a cancer kind of thing. What was the quality of life? So we had quality of life measurements that were validated measurements that we were looking at. And we had something called a functional assessment that really looked at your laboratory work, pain, leakiness of the skin, sort of by a system approach, it really looked at that. And so for patients that had capillary lymphatic venous malformations, it improved quality of life, it improved skin, and it also improved patients' coagulopathy, so people who had high D-dimers, sometimes the people who had high D-dimers and low fibrinogen, it seemed to improve that as well. I think overall, to me, the quality of life was the most striking, and I think it was the most striking in patients that you saw that really were debilitated because they had poor quality of life and were able to do more things and go out and be more interactive. I think that was the most significant thing for me. So what we then did is, there was a young attending, Adrian Hamill, who basically said, we have this prospective study, we're about at the end of the prospective study, and everyone seems, a lot of people are using sirolimus, but we're not capturing any of that information, and that would be good information for us to capture. And it would validate or not validate what we were seeing in the prospective study. So we looked retrospectively and we asked different people across the United States and across the world to see if they had any patients who were treated with sirolimus. And the same sort of data that we collected for the trial, and remember, a trial is prospective, you're looking at things kind of from the start to the end. Retrospective is it's already happened and you're looking at the things. So sometimes a retrospective analysis is a little bit harder than a prospective analysis. but we really felt we needed to combine them to get a better number to really look to see if this medicine was effective in these different kinds of phenotypes. And Kirsten Ritchie, who's sitting in the front row here, was a fellow who was working with us and now is an attending at Cincinnati, kind of put together all of the data on patients that had capillary lymphatic venous malformations. We were looking for the same thing. We were looking for a response, and we were also looking for toxicity. And what she found was very similar to what we found in the study, and here you see, so they're combined, but they're separated. So this is the retrospective patients, and these are the number of patients, and these are the prospective patients. And this was overall response. So again, that was that table that I showed you from the first study. So overall, the majority of people responded to this medicine versus a small amount of people who didn't have any response. And then what she did is she actually looked at quality of life, looked at the clinical response, and remember that was things like labs, like skin, like pain, those kinds of things, and also looked at the radiologic response. Again, the same thing that we saw in this study. No improvement really meant stable disease. Okay, so some people did have an improvement, but the majority of people just had stable disease on their imaging. But the majority of people had a clinical response, and the majority of people, as we saw with our prospective study, had an improvement in their quality of life. And so it really confirmed, though not perfect, the results of the prospective study. So let's talk, does anyone have any questions about that for right now? So really what we're saying is that it did, in this group of patients, it did look like sirolimus was effective. So let's think now about, so what are the side effects? And when I think about a physician telling you the side effects of these medicines, I have to make sure that you know all the side effects of the medicine. So I have to make sure you know the side effects, whether, if you take 100 people, 90 out of the 100 people had that side effect, or if 1 out of 100 had that side effect. And I also have to make you aware that if we're using this medicine for a different kind of reason, so a different kind of disorder, there may be side effects that we're not aware of. And so the most common side effects that we see when patients take sirolimus are mouth sores. And remember, side effects are different at different ages. So adults are not, kids are not little adults, and kids in general seem to do better with this medicine, as they do well with a lot of other different medicines. So I'm always more ginger when I'm starting an adult with this medicine, and there are different dosing that you use for an adult versus that you use for a child. And what I'm talking about as far as adult or not is when you get into those later teenage years, or the young 20s, the 30s, certainly the 40s, 50s, and the 60-year-olds are adults. So mouth sores is much more common in adult than it is in a younger child. Headaches are common, and that's why, if someone is starting with migraines, you want to know that. These are questions that you really need to ask. It's not that everyone gets a headache, so it's not that it's not treatable, and it's not that you sort of build up a tolerance to this, and so you might have a headache initially, but then not have a headache later on as you're using the medicine. So increase in your lipids, so your triglycerides and your cholesterol. So what do we do initially? We have people see dietitians to talk about what their diet is. So that's an important thing. If you're started on that, you might want to talk with your pediatrician or your general practitioner about that. You also want to know what your family is about that. So do you have a family history of hypertriglyceridemia in your family, or hypercholesterol problems? Is anyone on medicine for that? Those are all important things that we want to know as clinicians. For the younger kids, sometimes it can cause diarrhea, sometimes it can cause constipation, but for the infants and the younger kids, it seems more to be on the diarrhea spectrum. It can cause very mild anemia, and that's not iron deficiency anemia, though it looks like it on the laboratory reports. And some of the biggest issues for the teenage patients are that it can cause acne. And sometimes it's worsening of acne on the face, or sometimes it's on the chest or the back. But again, those are things that we can take care of. And then there are less common side effects. So remember, I talked about, you need to know whether 90 out of 100 or 1 out of 100 had that side effect. And so sometimes we think of poor wound healing, though when someone actually is having a surgical procedure on their malformation like a debulking, it actually helps because I think it controls the abnormal lymphatics that are there. And we know, and this is very, very preliminary data, that if we look at a venous vessel and a lymphatic vessel under the microscope after we actually give a mouse with a venous malformation or a lymphatic malformation, this medicine, it looks like it matures a leaky vessel. So the vessels look again more mature, and that's very, very preliminary. It also can change your blood counts. It is an immunosuppressive medicine, so we worry about infections. Though for that initial study and also the retrospective study, people were put on it if they had frequent infections, and it actually decreased the number of infections that they had. And again, I think that has to do with its effect on the lymphatic tissue. Sometimes it can have lung issues, so sometimes sirolimus can actually cause effusions. And like I said, we're using it to treat effusions. And I think those side effects were seen in patients that don't have vascular problems, but were transplant recipients. So you can see that. You can also see swelling of the legs as well. You can see high blood pressure too. So what about the dosing of sirolimus? So when you do a study, you have to be very specific about your dosing is. So what your dosing is. So everyone on the first study was given the same amount. We were shooting for a target level. So this is a medicine you can look at blood levels. And they got the same preparation. So you all know that there's a liquid form and there's also a pill form. And so we used a liquid form for the study, because we really needed to be very consistent and very methodical about this. But now we're using all sorts of dosing regimens, because now there are patients that we don't have to use as high of a blood level. And the adults, really, a better dosing schedule for the adults are a once-a-day dosing versus a twice-a-day dosing. And that actually helps a lot with their side effects. And again, dosing truly depends on what is your goal of treatment. So if we have a patient who comes in who is very, very sick from their vascular anomaly, we are going to shoot for a higher drug level. And we are probably going to be using twice-a-day dosing. And we're probably going to be using a level between 10 and 13. But if we have a patient that comes in and has blebs, has a lot of blebs or pain, we might actually start out, and as a 20-year-old, we might start out with a once-a-day dosing and get to 2 milligrams a day, and that patient might tell us, we're doing great. So those are all the questions about dosing that we're using right now. And really what we're trying to do is, what is the least amount of medicine that will give us the best effect? And we are working presently on another prospective study that's going to be open to many other institutions, where we actually will be prospectively following patients who are on sirolimus. It doesn't matter what level, what the dosing is, where we'll look at patient outcomes and also look at long-term safety issues. And so that should be coming out in the next 6 months. So what have we learned about sirolimus? So what we have learned is that the majority of the patients who are on this medicine, because it is a chronic problem, when they come off the medicine, their disease gets worse again. Now, people were worried that sometimes when you use sirolimus for different kinds of tumors, and we're talking more of cancerous tumors, and it's working and you take them off of therapy, then a tumor will come back with vigor. We have not seen that, but when patients are on it and it's improving their pain, and it might be softening their leg because they have clipalternane, sometimes when they come off of it, then that leg gets firmer again, and you might have more phlebitis, and you might have more lymphatic vesicles that form. So that's what we're talking about. Sometimes people can use it in an intermittent way, where you basically are on it and you come off of it, and if things get worse, you go back on it. And sometimes people just use it as what we call a maintenance way, and that's what we were talking about, the lowest dose with the best effect. And those are, you know, sort of some of the things that we've been thinking about. As far as long-term issues, because a lot of people ask me questions about this, so remember that first study was started in 2010. The treatment option of that was 4 years, and then we actually are following all of them. They were treated for a year, and we're following all those patients 5 years afterwards. And we have not seen any long-term issues. And so to be honest with you, I was a little nervous initially about cancers, because you're suppressing someone's immune system. But again, I told you it's being used for every different kind of cancer. The one thing that I warn people about is skin cancer, because it is an immune agent, and skin cancer, when you suppress your immune system and you're exposed to the sun, you can actually have an increased risk for that. So we talk about wearing a lot of sunscreen and family history and those kinds of things. But we have not seen any long-term side effects, and that's what we're watching for. We've treated patients as young as 3 weeks of age and as old as 67 years of age. Probably the long-term issue that I really want to investigate a little more are the cardiovascular effects, and also the metabolic effects. So if you have someone that has, obviously we're responding if someone has high cholesterol, and if they have high triglycerides, we respond with diet, and then we respond with medications. But I think that needs to be followed much more closely. So I'm going to go through some helpful hints now, and these are helpful hints for you and helpful hints for you to discuss with your doctor. And so you have to know that I'm like a neurotic clinician. So I get very upset if, like, I'm in Boston and I'm treating someone that lives in Nevada and I don't have any communication with them. So that's why it's so important for you to have someone locally that's going to help in the management of medical therapy. And again, this is very well tolerated, but still, it can have some significant side effects. And we need to know your disorder can have significant side effects. And I think the other thing that can happen is this can make someone's quality of life so much better that I think they forget about what it was like when they were having those frequent infections. So when someone gets a temperature to 101 and they haven't had a cellulitis or anything like that in a long time, I've had a couple of patients that have just waited at home for a little bit because they haven't had an infection in a long time, and that's not what we want you to do. I'm not looking at anyone in particular. So, sirolimus is a drug that needs supervision, follow up with a healthcare provider, and it absolutely requires laboratory work. So that's the other thing that some people think, my labs have been just so great, so I'm not going to bother checking my cholesterol and triglycerides anymore. But it really truly does need follow-up, and we can help with that. How often that needs to be done, it sort of depends on sort of where you are with your dosing. So side effects should be taken seriously. If you are having some sort of side effect and you don't know whether it's related to the sirolimus or not, and it might very well not be, you still need to talk to your physician about the side effect. You know, again, we're treating kids and adults in different sort of physiologic states and developmental states, and you know, sometimes people just, you know, ignoring things is so much easier than not ignoring things. But this is not something that really that should be ignored. And any illness should be taken seriously. And so I go over some other things in the next slide. But if you're not feeling well, if you have diarrhea, if you are vomiting, if you have a fever, those things really need to be taken very seriously, and you need to call your physician. That is one of the things that I work with pediatricians and physicians about, so to make them know that you're on an immunosuppressant therapy, and if you get sick, it's not like, oh yeah, that's going around in the neighborhood. You really do need to be evaluated. So when should you see your doctor? Well, obviously, if you have a temperature, so a temperature of greater than 101, we really want you to call the doctor, and hopefully if it is sustained, be seen. I also get worried if people have persistently low-grade fevers, because I think you're on an immunosuppressive medicine, and it might be just a virus and not causing any issues, but I think it's safer to be seen by a physician. We talked about any unusual side effects. If any side effect is there and it's not getting better, or it's actually getting worse. And any viruses, so chickenpox is one of those viruses, particularly in kids, that if you are on any kind of agent that suppresses your immune system, chickenpox, which usually is really tolerated in younger kids, can be something that's not as tolerated. So those are things that you should talk with your physician about and be seen. So what about immunizations? We get a lot of questions about that. And because someone is on an immunosuppressive agent, we usually suggest that no live immunizations are given, but that they receive all their immunizations that are not live. And what I mean by live immunizations, it's like the chickenpox immunization, the rotavirus immunization. We try to see when we're treating kids, if it's around the time that they're supposed to be immunized, we try to actually have that done before we start the medicine. So these are just other kind of helpful hints. Try to take the medicine at the same time each day. So remember, we're doing blood levels. So if you take it in the morning, try to take it at the same time in the morning. It's okay to miss once or twice. If you're taking it twice a day, again, take it at the same time and take it the same way. This medicine is really finicky. So this medicine, the levels can go up and down if you're sick with other natural products. Grapefruits are not something that you should be taken with it because this medicine is metabolized in your liver, and there's other things that also are metabolized in the liver, and it can make the medicine actually have a higher level or a lower level. So be super duper effective and be almost toxic versus not be effective. So it's really important that you understand what those things are. Important, the bottle, so if you have children who are on it, it's an oily substance, the bottle gets oily, so don't leave it in the container it comes in because it will fall through your hands and break on the floor. It needs to be refrigerated as well. Other things as far as when we had the adults who were taking the liquid suspension, the liquid suspension to me, because someone made me taste it, tastes like cardboard. And so they were holding the liquid suspension in their mouth, and I don't know, David, if this has ever if you've come across this, but the more you actually hold it in their mouth, the more higher your chances are of getting mouth sores. So just make sure that someone is taking it and then they're flushing it down, and usually orange juice is the best way to do that. We talked about things interfering. We talked about the importance of drug levels. You really do need to check those, and you also need to check your blood work. When you are ill, it's really important to check your blood work and to check a level, because as I talked about, the illness might increase the level of the medicine. So that's very important. We talked about already about being careful in the sun and using sunscreen. This does make you a little more sensitive to the sun, so sunburn, but then again, we talked about the risk of skin cancer. The other important thing to note is that, and people debate this back and forth, especially in the transplant world, there is a pneumonia, and it's called pneumocystis pneumonia. Does anybody know what that is? So it is a pneumonia that's caused when your immune system is suppressed, and we're giving you an agent that suppresses your immune system. And there is a simple medication, there's 3 of them, but you start with something called Bactrim that you can take 1 day a week. So we used to give it 3 days a week, but you can take it 1 day a week, and it's a preventative of this pneumonia. And to me, the risk of getting that pneumonia is so high, and the risk of taking an antibiotic 1 day a week is so low that I really recommend that all of our patients should be on what we call PCP prophylaxis. And something that goes along with that is because that it can cause mouth sores. Mouth washes will not prevent the mouth sores, but if you get mouth sores, your mouth is really dirty, and it can kind of keep your mouth clean so the mouth sores will go away easier and not get infected. So when should the medicine be held? And we kind of talked about this stuff as well. Always in accordance with your physician. So if you can't get in touch with your physician, it's probably better if you have an illness or a fever or something like that to go ahead and hold the medicine, but always contact your physician and let them know what you're doing. We do, we talked about that question about wound healing, and we talked about the issue of you do not need to hold the medicine if you are actually having surgery, like a debulking procedure to your lesion. But if you're having some other kind of surgery, it probably is a good idea to talk to your physician, because there might be other kinds of surgery that we do hold the medicine. Doesn't need to be held for sclerotherapy. So I go back to this very, very complicated diagram, and now we talk about, so what else could be out there? And there are other things that could be out there. So there's something called, there are AKT inhibitors that hit this pathway right here that are being used for other types of disorders like cancer. And there's a study that's going to happen probably in the next 6 months to a year for patients that have PIK3CA mutations and overgrowth. Because, we need a little more medicines in our armamentarium. We need to see if, whether it's a single agent or combination therapy that can work to help you all in combination, again, with surgeons and also with interventional radiologists. There's also, what would be ideal is to start at the top of this pathway and to see if there's a PIK3CA blocker. And we're working on that as well. But remember, we have to also think about what the side effects of these drugs are. So in conclusion, sirolimus is effective for the treatment of many vascular anomalies. The side effects are very limited, and I hope I didn't scare you with all of these helpful hints and warnings. There appear to be no long-term issues presently, and this is, again, 10 years out for some of the patients. Sirolimus needs supervision by an experienced physician. Sirolimus therapy is used as part, I can't stress this enough, of interdisciplinary care. Different dosing regimens are being investigated, and new medical therapy will be available in the future. And again, I want to thank you all, because if it wasn't for all of you and your support for us, we wouldn't be making these new discoveries. So thank you.